showing my screen. With your volume off here? Yeah. Okay. I'm going to press start now.
The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome everyone to today's Community Care Smart Assistive Technology webinar episode. By way of introduction, I'm Anne Livingston and I will be the chair and moderator for today's webinar. Today's webinar is titled How Wearable, Implantable and Sensing Technologies are Shaping the Ethical Landscape of Community Care Service Provision. This webinar is our 21st in this series, and we have been producing these since the inception of the Community Care Smart Assistive Technology Collaborative. Many would know that these webinars have been designed from feedback and requests we've received through the collaborative, and our webinars are bringing together local, national and international perspectives in research and development, as well as focusing on the deployment of smart assistive technologies in the provision of community care. It's great to have many in the audience who've attended all 21 of our webinars that we've produced to date, and it's again great to see that we've got representation from every state and territory in today's session. For those of you who have attended previous sessions, you know that community resourcing has been funded by the Queensland Government to bring together an online platform for community care service providers who are interested in collaborating on issues and practices related to incorporating smart assistive technology. Our project has achieved extensive statewide, national and international geographical reach, and this is growing daily. We'll provide some locations of upcoming regional, national and international activities that we're going to be directly involved in the coming months at the end of this presentation. As many of you would be aware, we've also recently been funded to revamp our platform, as well as putting together a consumer portal on the site. We've employed co-design and co-creation as well as collaboration concepts in developing this new area, and we look forward to the release of this shortly. As with all our webinars, we'd just like to note that neither Community Resourcing or the Department of Communities, Child Safety and Disability Services are promoting or endorsing any particular product, research entity or organisation. Rather, our webinars serve to inform viewers of examples of various smart assistive technologies in deployment or in development. Just some practical information about today's session. As attendees at today's session, and in the interest of recording, we have muted your microphones. If you have any questions, and we would encourage you to post questions, please add these to the question pane on the dashboard on the right of your screen. There will be an opportunity at the end of the session to have these answered. At previous sessions, we've been somewhat inundated with the questions, so please post your questions early to ensure that we can cover these in today's meeting. As I mentioned earlier, today's session will discuss how wearable, implantable and sensing technologies are shaping the ethical landscape, and importantly, are giving the opportunity for providers to explore what that means in community care service provision. I'd like to introduce to you today's presenter, Professor Susan Dodds. Professor Dodds is the Dean of Arts and Social Science and the Professor of Philosophy at the University of New South Wales. Her extensive expertise spans the areas of moral psychology, ethics and political philosophy. Her research is concentrated on ethical and political questions relating to human vulnerability, personal autonomy, respect and legitimacy, frequently focusing on gender and policy dimensions of these questions. Professor Dodds' research includes ethical and social impact of developing technologies and ensuring that emerging medical developments such as bionic implants and regenerative medicine undergo rigorous ethical examination and public debate. Professor Dodds has published extensively and a list of her recent books will be posted at the end of this session. Professor Dodds is also a Chief Investigator in the Australian Research Council funded Australian Centre for Excellence for Electromaterial Science, or commonly known as ACES, and in this role she leads the ethics, policy and public engagement themes of this centre. Susan also has a number of national committee positions, including having been chair of the National Enabling Technology Strategy, or NETS, Stakeholder Advisory Council in 2012, and she's been a member of the Australian Health Ethics Committee and a member of the Gene Technology Ethics and Community Consultative Committee. She's also currently a member of the Australian Health Ethics Committee, a Genetics and Genomics Working Committee. It's my great pleasure, Susan, to welcome you to today's webinar.
Thank you very much, and I'll just show my screen. Look, thank you for the opportunity to join you, and I'm very keen to get some feedback from your various participants about the ways in which we can ensure that wearable, implantable and sensing technologies, those smart technologies that can be made to get the benefits for those in community care rather than simply raising some concerns. I know that whenever I discuss these things there's a risk that I'm focusing on the negative rather than the positive, so hope that message gets across. So I'd like to begin by expressing the overview of the ethical landscape of community-based care, to talk about the ways I see there being a range of ethical issues that come up in that area of care, knowing that many of your listeners are much more expert than I am. They can correct me, but also they can see how I'm understanding those issues. Then I'd like to discuss the ways in which wearable, implantable and sensing technologies have been thought to have significant promise for care in the community, for supporting the lives of people who are clients of community-based care, but also to identify some of those challenges in those technologies and use an approach that I've developed with colleagues on human vulnerability and understanding different kinds of taxonomies of vulnerability in order to understand how those promises and challenges occur in their context, and through that to be able to identify some opportunities for responding to these technologies in a way that supports resilience and addresses those vulnerabilities appropriately. So I'll explain each of those things as I go through, and I'm happy to elaborate further in the questions. It seems to me that some of the characteristics that are salient for an ethical assessment of community-based care are, first, that it's holistic, that it is client-focused care, that it looks at ways in which individuals can continue to have meaningful lives in their community, or to have appropriate support. It also is an area in which the concerns about health, housing, disability and social services come together in a manner that I suspect most state and federal service areas haven't really thought their way through in detail. That we've got the need for community-based care to negotiate those complex relationships. It probably goes without saying that this is an area that's often under-resourced and oversubscribed. Most people would prefer, if possible, to have care available at home or in the community. Some people are forced to seek care at home or in the community if they're living in places where they don't have universal protection, and it's also the case that it's not an area that tends to get a high level of either state, or federal, or private resourcing. Very often community-based care is also dependent on family and unpaid carers, and therefore the provision of community-based care has to question assumptions it may have about the capacities and the support that's available for a client in their context. And it's community-based care often involves a workforce that has variable training and experience and has very limited training opportunities given the tight resourcing and high demands in the area. Similarly, the workforce within community-based care tends to be a feminized workforce, and it tends to be a workforce that has not had as much professional education as in some of the other areas of health service provision. At the same time, the kinds of work that these carers are expected to provide involves a full spectrum of care needs, and very often where people are working in rural and remote areas, that the care provision occurs a long distance from backup and support, and both carers and those who are cared for are often isolated. So if we then look at that context and that basic landscape, and we look at some of the discussions that have been occurring about the technologies that could be involved in community-based care, we can see that there's a burgeoning plethora of options in technology, all of which claim to be able to support patients in their home or clients in being able to live independently, but at the same time making all sorts of assumptions about the context of that care. So my focus today is going to be on community-based care, on connected technologies, and on the ways in which those technologies in that context may actually support clients and care service providers, and can also pose new challenges to them. So the range of things we might look at include wearable technologies. Some of them are wearable even if you didn't know they were, such as smartphones, but they include things like patient trackers and heart monitors, and the products I have here are just examples. There are many, many more that could be described. Some include things like an exoskeleton designed to support children suffering from muscular atrophy, and being able to show that these can assist people to have greater mobility. And then there's all the wearables in between, including some of the devices that may be able to monitor blood glucose and other health status. Implantables are, perhaps the rich kids on the block in terms of the technologies that are hoped to support clients and to assist people to live more independent lives. And among these, in terms of familiar resources, are the cochlear implant, which provides a neural stimulation through direct connection with the brain, as well as the developments in the bionic eye, and I used an old bionic ear institute example of what the bionic eye might look like, just to show that time passes. But they also include things like the use of deep brain stimulation for people with Parkinson's disease, the opportunities for neuromonitors, or the pacemaker as a really relatively mundane example at the moment. All of these improve patients' lives and make them less dependent for either hospital-based care or for other forms of support. And so the sensors include things like environmental sensors for assisted living, so that people can be monitored at a distance, or so that people can be able to turn on devices within their home or to monitor their energy use and so on. All of these are thought to have some opportunities. So that the idea of there being able to create a promise or an opportunity for community-based care Clearly, wearable technologies are thought to both support clients and provide mechanisms for service providers to provide a service more efficiently or to reduce the need for dependency on other individuals within those contexts. Wearable devices can include things that monitor health or the location of a person, provide them with reminders about the need to take a medication, serve as a communication device for people who may have speech difficulties. Similarly, they may provide physical support through exoskeletons or robotic devices or some combination across these. I'm going to be focusing today among the wearables on those which are connected devices, those which have frequently a Wi-Fi element to them which allows them to be either monitored at a distance or to be controlled through a smart device. In implantable devices, there's an assumption that these should be able to reduce people's dependency or the need for higher levels of care, assuming that we get safe and effective devices. And as I said, the cochlear and bionic eye implants are thought to address certain sensory limitations, reducing dependence on other kinds of support and facilitating social activity. In both cases, the initial intention in terms of what the cochlear would synthesize for hearing was to be able to facilitate communication between one person and another, and some of the examples of the bionic eye had as their first target to be able to allow for face recognition and to be able to recognize what's going on in another person's face. Neural implants that predict epileptic seizures obviously provide a degree of freedom for an individual living independently where they can't control their seizures through drugs and enhance their independence. But in all of these cases of the implants, we want to make sure that the devices themselves are safe and effective before they're implanted, and we may have some questions about how we can do that well. So pacemakers and implanted cardioverter defibrillators provide that kind of security and independence for patients. Whereas sensing technologies may be thought to have as their primary focus not so much the opportunities for patients to be able to, or clients to be able to live their lives and have something that supports their lives directly, but perhaps reduces the cost and intrusiveness of monitoring of clients in services, or to understand how people are using the space that they're living in, or whether or not they're getting adequate nutrition and so on, by allowing for some automation of some monitoring and some forms of support by triggering, having different kinds of triggers for connection. And that includes things like environmental sensors, which provide greater autonomy for individuals because they don't have necessarily the degree of intrusiveness of people coming to see that they're okay. But there are, as you might imagine, some concerns as well that with the monitors, we may find that people feel that they're being surveyed. We may ask whether or not it's using electronic devices to monitor someone's activity within their home may depersonalize opportunities for social engagement and mean that instead of having someone come and have a cup of tea with them or have a conversation with them and then socially engage with them, they may just receive an SMS message just checking, are you really okay? You don't seem to be moving very much. That seems to be perhaps a concern, especially for those who are more physically remote. So we've got a range of devices and new technologies that are available, but we need to make sure that to get the promises that they've been designed appropriately and that they've recognized the complexity of that ethical landscape of community-based care in order to realize them. I think that we've got challenges in how we're going to support these technologies and devices, whether or not we've got carers who are trained to troubleshoot a device and be able to ensure that it's working well. That often there's fragmentation in the understanding of what a device, the context a device might be working in, and therefore they tend to be designed around simple cases and not the kinds of complex needs which are frequently the needs of clients in community-based care, and therefore they may not be quite appropriate, may need some adaptation in order to work well with clients. That there may be limited engagement with users in the design, and so they may actually create further challenges or further dependencies on users because of certain aspects of the design which could be designed out. And there may be limited recognition of those contexts and of the tensions on care, community-based care services in order to be able to make the most out of the new technologies. So that's one sort of thing about the design of the devices and whether or not we've got the right model for design and implementation across the board. The second deal with the way in which connected devices by putting their data onto a cloud or having a mechanism for communication between a care service provider and a client, that there's maybe opportunities or risks of hacking, of privacy breaches, or even just basic mechanical or electronic interference with other devices, and that there needs to be a careful thinking through about how our dependency on the smartness of the device means that not all the potential beneficiaries of those devices will actually be able to use them safely. If it's the case that I lose my Wi-Fi access when I go further out of town, does that restrict me in a way in which previously I hadn't been? And finally, there's questions about the long-term support. A lot of these technologies are in their infancy, and it may be a little bit like the old days of video recorders where, you know, at some point we went between VHS and beta, and if you purchased the wrong video cassette recorder, you had a useless machine. That conversation itself suggests that the obsolescence of technology is always with us, because no one's seen a video cassette recorder in at least 15 years because we've moved fully on to DVD. Will there be risks associated, especially with implantable devices, for those clients who have you know, bought the wrong technology, gone beta when they should have gone VHS? And can implantables be disconnected? There's concerns about some of the cardioverter defibrillators that would disconnection of that device constitute, or discontinuation of it by Bluetooth, would that be tantamount to bringing about someone's death, or are patients able to make choices about discontinuing a certain kind of treatment in those cases? So there's specific aspects of implantable devices. Other issues and risks I think that if a care service provider may see are those associated with shifting of either liability or costs that may come from these devices. They are intended to provide greater efficiency, they're intended to increase clients' autonomy and safety, but it may be the case that they generate significant risks or costs for care service providers, which, as we said before, are often already resource drained. And so there's a range of challenges for both patients and care providers associated with them. The specifics associated with connectivity include those ones about hacking and privacy breaches or loss of service, and they have these other issues associated. I'm sorry, I've duplicated some of the content just there, but we do want to also look at those questions about updating. It's interesting to note that Deloitte has recently looked at technology-enabled care at home into looking at its financial implications and its long-term implications in the context of an aging population. So that's how I see the technologies, very briefly and very generally creating certain kinds of ethical concerns. I want to now look at ways in which ethics might be able to assist in thinking through the promise and challenges posed by connected technologies for assisted living, and to ask whether or not we can recognize the ethical aspects of the relations between carers and clients, because there's always a risk that the technology breaks into that relationship, and I think it's a really key one for understanding community-based care. So I'm now going to shift and sound a little bit more philosophical and talk about work that came out of a project I did with my colleagues Katrina McKenzie and Wendy Rogers on human vulnerability and bioethics. One of the reasons why there's a demand for, an ever-growing demand for community-based care is because humans are inherently vulnerable. We're all open to risk, to harm, to being wounded. Our lives can be affected by a range of things outside of us. But at the same time, we recognize that within our communities there are people who are more than normally vulnerable, people who are specifically vulnerable. So we have this idea that vulnerability is being something that applies to all people, that we're all vulnerable to pain and suffering, that if we're cut, we suffer, if we're vulnerable to hunger, if we lack food, to fear if we're threatened. But we also talk about people who are the vulnerable, people who are particularly vulnerable or vulnerable to particular harms because of their age, their health, their dependence on others, or their particular circumstances. Because we're all vulnerable, then the fact that we may sometimes be dependent on others for care becomes less humiliating. It's something that's true of all of us. But we have not really thought through what it means for everyone to be vulnerable in a significant way, and so that project looked at those sorts of issues. We looked at what the sources of human vulnerability might be. We see some as inherent. We use the language of inherent vulnerability to cover those sources of vulnerability which are just about what it is to be human and to be embodied. Things to do with our corporeality, our neediness, our need for affectionate relationships, and our social nature. So those are sort of the sources of our vulnerability to bodily harm or to want or hunger, our vulnerability to emotional harm, or our sense of being abandoned and isolated. Situational vulnerabilities are those which are actually more context-specific. They relate to our personal circumstances or our social circumstances, the political context. If someone's living in a civil war, their vulnerabilities are different from those who are living in a place of peace, those who are living in an area where the environment is extremely forbidding or have different kinds of vulnerabilities from those who are in different kinds of physical environments. And pathogenic vulnerabilities are those situational vulnerabilities caused or exacerbated by morally dysfunctional social relationships, those that are discriminatory. We might say that some of the attitudes towards people who are living with a range of disabilities often create situational vulnerabilities because we haven't properly recognized those social relationships and the way in which privileging able-bodied lives has an effect on disabled lives. Similarly, interventions designed to ameliorate inherent, to make better those situations in which people have vulnerability due to their inherent features or situation can be compounded by them. For example, if we create an opportunity for someone to have support and care in a care institution, but that they're in that environment makes them vulnerable to certain kinds of physical abuse, then we may say that that would be a pathogenic vulnerability. Realize this language may not be familiar to folk and happy to discuss it further. We also distinguish in our work between two states of vulnerability, to be dispositionally or currently vulnerable. A dispositional vulnerability is an underlying propensity or potential, that all women of childbearing age are vulnerable to the dispositional risks associated with childbirth, but they will only actually experience them if the situations in which they're giving birth are such that those circumstances turn into something which causes a harm or means that they're at risk of some other negative effect. So something is occurrent where it's immediately present or actual. And you can distinguish vulnerabilities that are not yet sources of harms from those that are currently causing harm and require immediate intervention. So by using the language of dispositional and current or underlying and present vulnerabilities, we want to acknowledge that a person who has, for example, a sensory disability may be at greater risk of harm in circumstances in which there's an emergency because they're not sensorily able to hear or see or whatever the alarms that are going on around them, but that'll only be an occurrent risk if they're in a situation in which the way in which we warn people about a fire is entirely through either one or the other of a visual or an auditory alarm. So that's the kind of distinction we're trying to draw out. So if we look at community care, then it seems that there are clearly the circumstances under which people become clients of care are very often inherent vulnerabilities, that they relate to their corporeality or their embodiment. It has to do with their physical situation or their emotional state and their affective relations. So for example, children who are dependent on foster care are clearly among those who have inherent vulnerabilities. There are also frequently people who have situational vulnerabilities, and as do carers, that a vulnerable person, a person reliant on care by others may be dependent because they're not able to secure their basic needs for daily living without support. They may be socially precarious in the sense that they don't have the resources they might otherwise need in order to secure what they need for life, and they may be isolated. But this is also true of carers working in community care. A large number of the care workers are in situations where they are dependent as well as being in a situation of relative authority with regard to someone who they care for. If you think about family-based care and in unpaid care work, clearly that relationship can be one that goes both ways for both clients and carers. And they frequently, carers being often poorly paid means that they're socially precarious and they may have poor training, therefore they have fewer job opportunities, and they may be lacking social connection and therefore at risk in their workplace. In the U.S. there's been quite a bit of work about the way in which private home-based care leaves workers in situations where they may be physically assaulted, for example. And so there may be pathogenic vulnerabilities affecting clients and carers, for example, failure to recognize the lives and the worth of people with disability, or there may be policies which are intended to reduce vulnerability can actually generate new vulnerabilities because of the way in which those policies apply, and I can talk about that in discussion. So connected assistive technologies in community care allow for certain kinds of situational vulnerabilities to become more visible. There's those responsibilities for maintenance, monitoring, and management of data can exacerbate the vulnerability of clients regarding the accuracy, currency, and protection of the data. The vulnerabilities may arise from surveying clients as well as for workers, and that pathogenic vulnerabilities may occur as a result of changes in policy, software, or systems which were not intended effects of the development of the technology. And I think that if we think a little bit about those use of connected assistive technologies in community care, you could see for any particular technology that we need to always look at the context within which it occurs in order to avoid some of those risks. So fostering resilience seems to me to take a step back and look at the very development of the devices or the technologies and look at ways in which clients and services can be involved in the design of devices and implementation. And clearly around the world there are a number of engineers, designers, researchers looking at new technologies which they see as assisted technologies, and there's opportunities, I think, for various client groups as well as care providers to actually influence and anticipate the way in which those technologies are developed, and I think that there is a greater awareness by researchers and product developers in the value of working with client groups in order to ensure they get appropriate technologies. There's a need for foresighting and risk assessment of the impact of the technology in its context to appreciate that if it's going to be used in a community care context, that's going to be very different from the acute care context, and that the resourcing and the robustness of the device needs to be addressed. Recognizing the policy gaps and conflicts and questions about whether or not we need to have any special regulation or legal protections associated with care providers using a new technology where they may be creating an opportunity for private information to get into the wrong hands. How do we, where should we fill that gap? And similarly, the legal and social recognition and status of care providers, of product providers, and of clients may in some cases need to be clarified in order to allow for appropriate legal claims should there be concerns. Looking at the ways in which we might develop carers and client skills and education in the development of these technologies, I think needs to go hand in hand with the development of the technology rather than something which is thought of after the fact. And a realistic assessment of the resource needs and efficiencies for these technologies to come in. Very often new technologies are offered up as a way of creating a great efficiency, but in fact for them to be used appropriately and not to create pathogenic vulnerabilities, there needs to be appropriate resourcing behind them. And so if we address the recognition of the inherent and universal vulnerability of people, it seems extremely likely that we'll think differently about how to foster resilience and how to develop technologies and to implement them in a way that doesn't generate greater concerns. So just in closing, it seems to me that the discussion about assisted technologies, while often individualizing clients within care, actually should support an understanding of our solidarity and our relationships with one another, that we don't want to use the technology to fragment the relations between people, but rather to bind them together. And so it seems to me that community-based care services need to be understood within the broader context, and we need to focus carefully on how the technologies can support resilience rather than to generate new vulnerabilities. So just like to acknowledge the research group I've been working with in this area and to thank you all for listening.
Thanks, Susan, for a great presentation. You presented us with a range of considerations, I guess, that are really front and centre to considerations of community care providers who are going down the journey of maybe incorporating bits of smart assistive technology in their service provision, or indeed trying to mainstream and disrupt, I guess, the service landscape by providing services enhanced by technologies in a greater way. I've got a number of questions already on the panel, and I'd encourage anyone else who's got some questions that they want to ask today to post those now so we can consider them in today's session. On your screen now are some of the current books that Professor Dodds has published and been involved in the research, and I'd encourage you to access many of those. They're great resources. Susan, I've got some questions around your comments around policies, and I guess the question lends itself to two comments. One about, you made a comment about NDIS and some of the policies might have unintended consequences, and the questioner would like you just to elaborate a little bit more on that. And then further, we're seeing with the emergence of particular situations or cases that are before courts or have been before courts. Probably front and centre at the moment is the South Australian example where a family carer introduced surveillance. And what really has been identified is our lack of policy parameters and our lack of exploring these issues in community care. Can I ask you if you'd like to comment firstly on the NDIS example you raised and any comments you would have about the gaps in policy.
Yep. Thank you. The NDIS, I think, in its intention is a fantastic advance in many ways. But in order for it to be seen to, to have got through, it has been designed in ways that take for granted certain kinds of social contexts. For example, assumptions about the capacity of unpaid carers or family-based carers to support people both financially and physically in many cases, and therefore making both people who may be dependent on others for care vulnerable to the capacity of their unpaid family carer to actually realize their needs in some ways, but also making those carers vulnerable to poverty because they need to attend to the person in their family who has one or more disabilities. So that's one kind of example where I think the policy may have an unintended effect of generating further vulnerabilities, but it also, may make people more vulnerable where there are, by focusing on the client and providing them with effectively an insurance process, so it supports them to realize certain kinds of a baseline of life capacity, that it actually can fragment and cause gaps to open up in service provision because individuals are purchasing different aspects of care or packages of service without someone asking, robustly whether we're generating an opportunity for care providers to just go for those things that are going to bring the biggest return, because I assume that there's some areas of disability services which are never going to be financially self-sustaining. So we're bringing together the marketizing some of the aspects of service provision together with individualizing the funding means that there isn't a continuity of service provision necessarily. There may be gaps in remote and rural communities. Those sorts of policy decisions, I suspect, were not intended. I know they weren't intended, but I suspect they weren't really thought through. And so, it's about taking a step back and asking, well, okay, this is a policy intended to deal with disability, but it actually has effects on housing, on the lifetime earnings of family members. It has effects on everything else. So how can we look at that? Now, the South Australia example I'm not particularly familiar with, but the policy gaps I am familiar with. It is often the case that with a new technology that we approximate the regulation or the coverage of a new area or a new technology by looking to similar examples in the past. And so if you think about medical device technologies, people will always look for what's the nearest example to it. But when we go for these significant shifts where we might be implanting a device which also has a Bluetooth communication aspect to it, to a computer which then stores data on, in the cloud, which is my personal health data, at the same time as being simply a record of whether it's my, EEG activity or whatever it may be, that we don't really have policies ready set for those areas. And we may find that questions about, well, what if what if it's the case that the Bluetooth connectivity is a bit dodgy, so that the data that is stored about me is not quite accurate, and therefore I'm getting offered a treatment which is not one that's appropriate for me if it was the case the correct data was there, or if the information is getting released and therefore someone else can manipulate the data that's held about me, and therefore someone can intervene in my health or intervene in my private life. I think we've got some of the basic privacy principles well sorted within the Australian context, but I don't think we necessarily have thought about all the new ways in which questions of interference with data and questions about who owns it, who controls it, who has responsibility for monitoring it and assessing its accuracy haven't been thought through.
Yeah, thank you, Susan. I guess the next question is from Jenny in a rural and remote area, and she asked a question along this agenda of policy. Jenny asked, how would you advise the sector how to push up the ethical considerations on the agenda of policy in a positive rather than reactive way, which we seem to get now?
Look, I think one way is to identify the aspects of the technologies that are really positive and enabling, but to at the same time say the support we have for these positives to be realized is limited because, and so trying to demonstrate that there's certainly a recognition of the need for efficient delivery of appropriate services within the community, but just pulling out the kinds of gaps that may be readily addressed by simply having, some ratio of support and backup for the people who are trying to implement and trying to ensure that we're not going to run into difficulties, and showing that in terms of the impact on both individual lives and the continuity of care that can be provided. I think rural and remote communities is a very strong area for suggesting that in the absence of some kind of integrating function, you won't actually be able to sustain appropriate services, even if you've brought in all the most efficient new technologies there are. If you don't have someone who can go and change the batteries or whatever it may be, you won't be able to realize some of those benefits. So I think that clearly there's opportunities for the sector to work, for example, with educators, whether that's in the TAFE or university sector, to say, okay, if these technologies are coming in, how do we skill up our workforce? There's opportunities for demonstrating being on the front foot in terms of trying to work with the client base to find out how well they might adapt to the technologies, and I think sometimes it's a bit of stereotyping goes on in assumptions about how adaptive people are, but clearly the sector needs to find, critical friends, those who are willing to take the argument forward with them and to demonstrate the kind of shifting of care support that's been provided from within healthcare institutions, narrowly understood, to the community, and identify the ways in which that requires substantial support.
Thanks, Susan. I've got a question from Jason. Jason's actually a Western Australian a participant in our collaborative, so welcome, Jason. Jason alludes to, points to some of your comments about the workforce development aspects that are required with the introduction of new technologies, but new roles emerging in the sector. And he's just wondering, in respect to those new workforce dynamics, I guess, and also new training requirements, are you aware of much involvement that's occurred with unions and what union stats might be?
I certainly know that when I was sitting on the National Enabling Technologies Strategy Stakeholder Advisory Council, which is a mouthful, it was that there were Unions Australia was involved in those discussions, and I also know that within the UK, and I wish I had the reference directly in front of me, I might be able to send that through to you a bit later. The UK did a report on emerging technologies and the futures of work, and it was much broader than smart assistive technologies, but it encompassed that as well. and it asks some of those questions about what kind of workforce will we need. I can give a couple of examples more at the medical end than the community care end, but you might imagine if we're going to be 3D printing hip joints rather than just using off-the-shelf ceramic or titanium hip joints in the future, there will be a technician in the room running the 3D printer, and I assume that the 3D printer technician will not be a surgeon and will not be simply someone who sells a standard medical device, but is actually developing a new device and a new bit of material that's designed around that particular patient, and therefore there's a new set of skills, a new set of liabilities, a new set of responsibilities, and the surgical staff and hospital staff will need to be able to work with those people effectively. Well, you could imagine a comparable case where even now the design of prosthetic limbs, there is quite a bit of use of 3D printing and body imaging required in order to make that work, and there are additive biofabrication degrees actually coming up around the country in response to that, and some of them are looking at 3D printing in general, not necessarily for medical use. Some of them are looking at more the medical specializations and medical tools that can be developed. You can imagine assistive devices for people who have either mobility concerns or problems with grip and problems with being able to hold or carry things, that if you could 3D print something which was appropriate to that person's body morphology, then you get something which is really more useful for the person to use rather than using the usual foam and sticky tape approach. That means that there will be people who have responsibility for making sure the materials they're using are safe, that they're thinking about the forces that are involved in the materials, the things that they're printing, and so there'll be a range of new jobs associated with those. In the connective case, I think that there's going to be a number of opportunities, especially from the client base, for thinking about how to code apps that are appropriate to people with different kinds of care needs, or different kinds of not even care needs in some cases, just different kinds of ways of communicating and engaging with the technology. I think there has been some work in TAFE done on this. A lot of it's come around focus on aging populations, and now is beginning to come into disability, but it is the case that the education will always lag slightly behind the technology.
Thanks, Susan. We've got a few more questions, but I've probably only got time to take one, and so I apologise to those people who posted questions. We'll certainly share those with Susan and provide answers. But thanks, Scott. I'll take your question next, and I guess it's a question and a comment or a statement. Scott says, technology or user need-led change is at play, that perpetual challenge. Susan, what would be your top 2 priority areas where you see the biggest technology need?
Look, I think this is where getting users and clients to articulate what, based on what they can see is happening around them, if they can articulate things that they could see as projects that they want someone to explore into, that there seem to be a large number of people keen to do small-scale, high-quality, smart technologies, and that if people can work up from those ones, then that would be a much stronger way of doing it rather than having it be technology-based. In my view, maybe I'm just a Luddite, so I tend to see more how I respond to technologies as they develop and anticipate what they may cause than to be always on the lookout for a new technology. I think that we will never get beyond the need for human-to-human care, but if we can reduce some of the activities which are either awkward, demeaning, boring, repetitive, and not very pleasant for any people involved, and find ways in which we can have technologies engage in those areas. That would be fantastic if that meant that we could free up the human folk to be able to engage on the more meaningful, more valuable, and more supportive areas.
Great. Well, thank you so much, Susan, for opening this discussion, because I do think it's a discussion that will continue. And I think you've raised some really very critical considerations that are perhaps not highest on people's agenda at the moment. And I guess through the work of the Community Care Smart Assisted Technology Collaborative, that more and more people are identifying the need to explore these questions more thoroughly. I guess one of our roles for the Queensland Government is also to input into policy discussion, and certainly I think there's other states and territories governments who have an appetite to explore this situation further. On behalf of everyone today, Susan, I'd like to thank you wholeheartedly for your time this afternoon. We hope that this will be a continuing dialogue, and we would like to explore in depth some of the concepts that you've raised today. So on behalf of everyone, thank you very much for your time.
Thank you very much. I certainly have enjoyed it. I hope it was helpful. Thank you.
Thank you. Just to end today's session, I'd just like to highlight some upcoming activities that we have in respect to the collaboration. We'll be doing some consumer activities on the Sunshine Coast early next week, if anyone's interested from that region. We're also taking a study tour into Canada, and we're looking particularly focusing on the EU network of living labs, and we're going to bring some of that research back to the collaborative, and particularly focusing on our upcoming launch of the consumer portal, where really the focus of that consumer portal is about consumers being involved, individuals being involved in design, development and deployment of technologies. We also will be featured at the Queensland Disability Conference, which is being held in Cairns on the 24th of August and satellited into various parts throughout the state. So we'd encourage your involvement in that, and to go and see Liz and Imogen at our stall at the conference. On the 23rd of September, we'll also be presenting at the Entrepreneurial Business and Community Care Conference, which is being held in Brisbane. And during September, the middle part of September, we'll be travelling through the Burnett and Wide Bay areas. So if any people on today's webinar are interested in being part of some of our activities in those areas, we'd welcome you making a contact directly with us. Remember to register for upcoming webinars through our site sapcommunity.com.au. And as I said, September's topics will include living labs, concentrated some webinars on robotics, and discussions on smart cities and smart transportation. I'd like to acknowledge the people who brought together today's session, particularly the Community Care Smart Assisted Technology project team headed by Liz Dodd, and also the expert reference group that come together on a regular basis and advise us on the developments in the collaboration. Particularly, I'd like to acknowledge the Queensland Government for its funding and support of this project, both through the Department of Communities, Child Safety and Disability, and through Innovate Queensland, and particularly the Advanced Queensland Community Digital Champions program, of which several members of our expert reference team and our project team have been acknowledged. But specifically, I'd like to thank you, Professor Dodds, for your presentation today. believe that this is an area that is really emerging in the work of the collaborative. So we do look forward to some further dialogues and to exploring the ethical agenda of delivery more thoroughly. So thank you again, Professor Dodds, for your involvement today.
Thank you.
Thanks, everyone.